So thank you for inviting me to the 2022 NBSTRN network meeting. I'm going to be presenting our BabySeq2 product and how it advances newborn screening research. So there are many treatable conditions in childhood. It's estimated that about 1 in 135 babies are born with a genetic condition that can be treated in childhood. And there's a variety of these types of conditions. So there's conditions that have a specific medication available for treatment. There's conditions now where either stem cell or organ cell transplant can cure the condition, and those are probably increasing. There are a number of disorders where there's a specific medical procedure that can be done to manage the disorder. A number of disorders are treated with supplements or a special diet. The disorders where a special protein, enzymes, or immunoglobulins, for example, can treat the disorder. And there's gene therapy approved to right now for just a few disorders, but as time goes on, there are going to be many, many more disorders that are going to be treatable potentially with gene therapy. However, the reality is that the genetics newborn screening program captures very few of these disorders. So it's about 35 conditions on the RUSP, the core conditions on the uniform screening panel. And so all the disorders that I just showed on the previous page would not be picked up with newborn screening. In particular, are time-sensitive gene-targeted therapies that are constantly being developed, and this is an area that is going to certainly increase dramatically with time. So not only are few of these on the recommended uniform screening panel or the RUSP, but it's a very slow process to add new conditions to the RUSP. So if we think about genomic sequencing, the reality is that thousands of conditions could be screened for simultaneously if we used newborn genomic screening and integrated that into the newborn screening program. And I'm going to talk about the BabySeq project, which really looks at how potentially doing such overall genomic screening in babies could increase the number of disorders that are detected and then can be treated in childhood. So this leads us to the BabySeq project. So the goal of the BabySeq project was to examine the clinical utility and impact of genomic sequencing in newborns. So we looked at the medical impact. So what's the impact on the individual and public health? We looked at the behavioral impact. So what is the impact on physicians and patient behavior? And we looked at the economic impact. So what kind of impact is there upon cost for the healthcare system? So the BabySeq2 project was a randomized controlled trial of whole exome sequencing in healthy and sick infants. And so we had an ICU cohort, which was mostly the NICU and some children, babies in the cardiac intensive care units. And then we had a healthy newborn cohort, in which within each cohort, we randomized babies to either standard of care, which included also getting a detailed family history, or standard of care, the family history, and whole exome sequencing with return of the results on a whole exome sequencing report. So we disclosed the results to the parents. We sent the results to the pediatricians and the neonatologists and other doctors caring for the newborn if they were in the intensive care unit. And then we reviewed in the medical record. And as you can see on the right there, we then looked at infant, parent, and physician outcomes. So if we look at what's currently on the kind of core conditions on the RUSP and the conditions that are in the ACMG list of actionable conditions to return, there's very few. So it's about 35 conditions in each, and the ACMG is 73 genes. But we talk about returning conditions in BabySeq. We really looked at, was probably over 1,000 conditions that potentially could have been returned to the families as part of the BabySeq project. So these 1,000 conditions and genes were kind of divided into kind of three groups. So there was a childhood onset with strong evidence of penetrant and strong evidence and high penetrance, which were returned. And then there were conditions that had moderate evidence and penetrance, but the clinical actionability in childhood was high, and then returned. And we did not return conditions with limited evidence or low penetrance. We did, about halfway through the study, start to return the results from two conditions on the ACMG list that were highly actionable, then those had been added later. So these are kind of give you a sense of the what the criteria were for returning results. And then we returned pathogenic and likely pathogenic variants primarily. We also had an ability to do an indication-based report. So if a child had a particular indication, such as seizures or hypotonia, we then returned, similar to kind of a clinical scenario, we did return the US's, but generally it was pathogenic and likely pathogenic variants. And then we conducted surveys to look at the impact on healthcare providers and on parents. So the upper part here is just the surveys of parents. So we did a baseline survey at enrollment, a survey right after they received a result. So again, this was in both the sequencing and the control group, 3-month disclosure survey and a 10-month disclosure survey. And then we returned the reports to primary care care providers and did surveys when we returned the reports, as well as an end of study survey for providers. So there were 159 newborns in the genomic sequencing arm. There were 31 from the NICU and the cardiac intensive care unit, and then 128 well newborns. We did have indication-based analysis requested for 29 of the newborns from the NICU and 6 newborns from the well baby nursery. These are kind of basically our really primary findings. So in 11% of babies, we found, we call an MDR, so monogenic disease risk finding. And they kind of are listed here. So there was a number, 4 of them here where there was phenotypic evidence in the baby of the finding when we kind of looked for it. There's a group of them here where there's a family history that was in the rest of the family that was consistent with the finding in the baby. And then we had a group here where there was no phenotypic evidence of the finding in the baby or in the family history. And then we did kind of importantly looked at the impact on parents. And we really did not find kind of deleterious impact on families. So these are divided here. So this is the control group in yellow, the group that underwent sequencing in blue, and then this green bar are those who underwent sequencing and had a monogenic disease risk. And as you can see, there's no increased risk, neither the sequencing group or the monodisease, the MDR group, in terms of parental depression, parental anxiety, parental self-blame, or parental perception of their child and relationship. So in summary, the BabySeq project really was the first comprehensive sequencing of healthy newborns. 11% of babies had a health-related monogenic disease risk finding, and there was no evidence that this information upset parents or increased healthcare costs. However, almost all the parents who enrolled were white, non-Hispanic. So these are our demographics, and you can see 76% of the parents were white, and then we had some Asian, few African Americans, and a few others from the racial categories, and 82% were non-Hispanic, 6% Hispanic, and 12% missing. So it was clearly the demographics were really showed us this was really not a very diverse population. So if we're really thinking about integrating sequencing into newborn screening, we need to understand the impact on and gain acceptance of all communities. In addition, engaging in underrepresented communities in genomic research will improve our knowledge of human genomic variation. It will enhance the ability to use genomic information in the medical care for all populations. So this leads us to the BabySeq2 project. So the BabySeq2 project is an implementation study of genomic sequencing and screening in infants from underrepresented communities that are underrepresented in research. And we're really doing here is trying to expand on and improve on what we learned in BabySeq, in the initial BabySeq project. So this is funded by the NIH, primarily NCATS. There's also some funding coming from the NICHD. The coordinating site is a Brigham Women's Hospital, and the clinical sites are Boston Children's, Mount Sinai Hospital in New York City, and the University of Alabama at Birmingham. So this is a UO1 from NCATS that requires the participation of 3 CTSAs, and these are at the 3 institutions here. The sequencing is being done at the Broad. We have economic analysis that is being done by collaborator at Harvard Pilgrim. The surveys and a lot of analysis will be done at the Baylor College of Medicine. And then we have a provider, some provider training that will be done by Hudson Alpha Institute for Biotechnology. So we have 3 aims, and I'm going to list them here and then go through them in a little bit more detail. So the first aim is to enroll 500, we say apparently healthy, but just 500 essentially babies from an ethnically and racially diverse communities, 0 to 6 months of age, into a randomized controlled trial of sequencing. And I should say that at this point that when we went to the Brigham Well Baby Nursery, which is where we enrolled in BabySeq2, the population in that nursery is very diverse. The issue was that the people or the families that enrolled tended to be white and non-Hispanic. So in BabySeq2, we are going out to communities, to kind of underrepresented communities, communities of underrepresented individuals, to enroll directly in those communities so that we increase our chances of really enrolling a more diverse cohort into BabySeq2. We're providing the healthcare providers through structured curriculum, and then we're turning results to families. And then in the second aim, we're looking at the impact on the families and the providers, and then exploring the healthcare utilization and associated costs. So because of this issue of distrust in research and genetics among underrepresented minorities, we took a couple of different approaches to really gain acceptance in those communities. So first of all, we initiated a stakeholder board, which has community representation from all 3 sites, that meets probably every 3 or 4 months and has provided some very valuable input so far into our study. And then we've been soliciting parental input from these communities to understand their concerns about genomic sequencing research and how we can address those concerns as we develop our protocol, recruitment strategies, and disclosure methods. And so we've been doing interviews, and I've listed here some of the things that we've been asking about. So asking about their beliefs of genetics, barriers to participation, concerns about the study, which we described to them, the type of information they want back, and what kind of outcomes and study results they think would be interested. And these we've been doing over the past year and are putting together now as we develop to help kind of inform the development of our protocol. The second part of this aim 1 is what I've alluded to already, is this training of healthcare providers. And when we submitted the grant, initially there was concern from the reviewers that providing this type of information, genetic information, to primary care providers who are already, very busy, overworked, very neat kind of complex patients, that it would be really difficult to just hand this type of information. And so what we developed was a training program. And since we're enrolling in clinics, and potentially there will be a number of participants from one particular provider, we are doing a training session, which we are offering the MOC Part 4 credit for the American Board of Pediatrics, to help healthcare providers understand the whole genome sequencing, understand the contents of the report that we're returning, understand, help them kind of train in what to do with the results and how to counsel parents. So there'll be a kind of a short training session. There's one kind of live section and the other online sections, and then some surveys done. And then once they've gone through the training, we will enroll only patients of providers who have participated in this training and recruitment. And this just shows the number of providers at each clinic. And these are some results from the previous Hudson Alpha study that they did with SouthSeq with their genomics education program, that just shows how the reported level of confidence in providers increased with this genomics training. And then the third part of or part C of AIM-1 is to enroll these families and either into standard of care with a kind of family history report that we'll obtain when they enroll, or that the same with the genomic sequencing, disclosing results, and then conducting post disclosure surveys with the families, as well as a 6-month post disclosure survey. So we then returning the results to the families, as well as the providers. We'll return results to families. A genetic counselor will do that. So we'll have put together a family history report, as we did in BabySeq, the first BabySeq project, that just kind of goes through our findings and any recommendations from the family history. And then those in the sequencing arm will get a report that'll look something like this. It looks a little bit different, but just to give you an idea, it's a very extensive report. We are enrolling, trying to enroll a significant number of families that are Hispanic, and so the reports will be in Spanish. We'll are hiring a genetic counselor who speaks Spanish, hopefully, to return the information. And then we will be returning the family history report and the genomic sequencing report to the healthcare provider. And then we have this, what we're calling it's a kind of virtual resource center, the Genetics Resource Center, which is essentially just meaning that we are available, the study staff and genetic counselors available at any time for any questions that either the family has or that the provider has about how to follow up with the information provided through this study. So the second aim is to look at the impact on these infants, their families, and their healthcare providers. And so we're kind of building on what we did in BabySeq, the first BabySeq project, conducting these longitudinal surveys, as I said, planning to do them at, so there'll be a baseline survey and then a post-disclosure survey and a 6-month survey. And so looking at really similar domains, so the parent-child relationship, the parents' partnering relationship, and then personal distress, so kind of depression and anxiety. And this just looks at kind of some of the domains and the measures. And we'll be using many of the similar measures or the same measures that we used in our initial BabySeq project. And then we're looking at the medical impact of genomic sequencing on the infants and their families. So we were reviewing the medical records, finding out about any symptoms or looking at any laboratory or diagnostic results, new diagnoses, or medical actions attributed to the findings. And again, because we're enrolling in clinics, we'll be able to get most of this information really from the medical records and from the clinics. And then to look at whether or not any findings of monogenic disease risk findings reveals an unsuspected phenotype in the infant or family, explains a family history of the conditions, or prompts surveillance in the infant or family. So again, similar to what we did in the initial BabySeq project. And then looking at the impact on clinical care. So we'll be collecting feedback from healthcare providers throughout the study by looking at the use of the Genomic Research Center. And we will, towards the end of the study, conduct interviews with the providers to really get kind of in-depth feedback on how things went and what they feel that this, how this impacted their clinical care. And finally, we have an exploratory aim to look to evaluate the healthcare utilization and the associated costs of genomic sequencing. And so this just kind of illustrates some of the strategies we're using, look at attributable services, genomic services, as well as kind of all costs. So how does the BabySeq kind of inform the mission of the NBSTRN? So the NICHD supports many activities that advance research in newborn screening. And so recent efforts have explored the use of genomics in the neonatal period, conducted prospective pilots of conditions that are candidates for nationwide screening to evaluate clinical benefit, and developed novel screening technologies. So the American College of Medical Genetics and Genomics plays a key role in these groundbreaking efforts by leading the NICHD-funded Newborn Screening Translational Research Network, so the NBSTRN. So the NBSTRN is a key component of the Hunter Kelly Newborn Screening Research Program that began in 2008 as an effort to engage a variety of stakeholders across the newborn screening system. So the NBSTRN has now matured into a dynamic and committed network comprised of researchers, healthcare professionals, state newborn screening programs, families, and advocate groups. And the team at the ACMG is beginning its 14th year now with a renewed mission to facilitate the discovery and validation of novel technologies to screen and diagnose disease, pilot new technologies and treatments, describe the ethical, legal, and social implications of MBS research, and collect longitudinal health and genomic data. So I'm currently the chair of the NBSTRN steering committee, and I think efforts like BabySeq will help, or certainly hope, will help advance the mission of the NBSTRN by advancing our understanding of the use of the genomics in the neonatal period. And the NBSTRN is really also partnering with us in BabySeq in terms of things like data collection, common data elements, and these type of things. So we really are taking advantage of a lot of the efforts of the NBSTRN tools that they offer to help us, particularly with the data collection for this project. And this is just a list of our teams. So as I said, we're funded primarily by NCATS, but also in part by the NICHD. We have a small grant, or have a small grant from the Greenwell Foundation that's responsible for some of the interviews that we're doing. And then we have a number of philanthropic partners as part of our funding. And this just has kind of the research team leadership here in Boston. So Robert Green and I are co-PIs of the overall grant. Carol Horowitz and Bruce Gelb are the PIs in New York City, and Bruce Korf in Alabama. These are some of the people with who work with us who are invaluable to our project, and if we didn't have them, we wouldn't be getting very far. So a big thanks to them. So thank you very much for your attention.